Okay.
Yeah, beautiful. Now this case.
Case number 5.
Yeah. This case actually, let's go. We started with the patient, 62-year-old female who had chest pain and dyspnea. As you see, that this time we have clearly avoided the Canadian class as per guidelines of the AUK. Remember, AUK also, they had taken away Canadian class completely because majority of these patients, they don't fall into Canadian class because they don't have chest pain. They have dyspnea, their shortness of breath, their limitation, their activity. So clearly, based on that, I think overall, the patient is symptomatic or ischemic. That is where the whole case of the ischemic heart disease is being counted. So this patient particularly had risk factors of diabetes, hypertension, high lipid, positive stress test, and is in good medical therapy. Cath was done, 3-vessel disease, and had a syntax score of 24. And the patient had discussion with the surgeons, although you can make a point that maybe particularly with the 3-vessel disease, diabetic should refer patient for surgery. Yeah, we do refer, but after discussion, half of them, we have our own data that after discussion with the surgeon, the patient comes back to the interventionalist because of this guy heart team and patient preferred surgery, or sometimes surgeon refuses the patient having a cabbage. So this patient actually had a rota stent of the OM, didn't look that calcified, but see the RC, the LV is good. RC has a diffuse disease with a total PDA, which will be this is that OM, which was very tough to crack. After balloon dilatation didn't open, then they did a rotablation and then put a stent which Promus Premier 2.524 came out very good. And today is here for LAD diagonal bifurcation with a moderate calcium. There is a disease at the ostium of the diagonal, so you can call it a 111. Although the diagonal is about 2.25 millimeter vessel, there is first diagonal, which is diffusely diseased, moderate size. There is no disease of the LAD at that place. So we felt that we just concentrate on the mid LAD, although it looks like only mild little flakes, but we know, particularly this particular case, only what little flakes into the circumflex, that had to do a rotablation because lesion did not crack. So we said, well, we do IVUS and try to learn a little bit what is the lesion morphology. So we did the IVUS here. They're going to change to IVUS, and you can see that yes, the calcific we play. So one area of the calcium was 1 quadrant, and the second area is 2.5 quadrant type of calcium, but not a circular. The cases which we have showed today, the circular calcium, though this one is still was the 2 quadrant calcium, and as you know, it takes not much from us threshold point of view because of the history, what happened in this particular case in the circumflex, we felt that let's just quickly do a rotablation. Then that is what we did.
So before you go, yeah. I know you're choosing. So again, it's another bifurcation calcific lesion. But the question of whether or not we need rotational atherectomy or what about orbital atherectomy in a case like this is something to be talked about. We have a great panel. New to the panel is John Fox, Cindy Grimes, Stefan Windecker. Who else am I missing?
While you continue, because I'll tell you reason is because we have beautiful case, one more case ready. But yes, these are a very good point. Whether you use a rotational orbital, I think any one is a dealer's choice in this kind of case. Few cases which we discussed earlier where orbit versus rotational is preferred. But here, yes, if need to be, you can use any. And this is done by Joe, and we are dilated with a balloon. And we felt that it's a small vessel, side branch, 2.25, just do a flextome, cutting balloon, and we had done 2.25, the multiple dilatation. And this is where we are. So ostium looking perfect, LAD here. We decided to begin with in this case that we are going to do a 1 stent approach in the LAD, and we are ready now with the 3028 synergy. While you're having a discussion, we are just going it because we will want to finish this case quickly and then go to the next one, which they are ready in next few minutes.
I think this case does generate some nice discussion. Any comments from anyone on the panel? Cindy, would you proceed in this direction? What did you think about the cutting balloon and no stent, in a single stent by putting a cutting balloon on the side branch?
Well, I think that's a great idea to do a single stent strategy. And in my personal experience, we have a lot of recoil from osteal lesions. And so I think using a cutting balloon or a scoring balloon is a very reasonable thing to do. And plus the angle of takeoff of that diag is quite shallow, right? So if you were going to stent that, it's definitely going to impede flow in the LAD. So it's going to end up being a crush or some other complex technique. I don't know about the rotablator. I think once you do the IVUS and you don't see that huge arc of superficial calcium, I'm not sure whether it's absolutely necessary, but they certainly got a great result.
Any other comments, Stefan?
Roxana, I think the operators have the privilege from the previous experience, and I think this is very important. So if they encounter the difficulties in the marginal branch, I also would have a very low threshold to have a very good lesion preparation in the LAD. Is it absolutely necessary? Probably not. But I think as you already have seen the result after the lesion preparation, it's excellent. So I think it was a good strategy.
It was a good, yeah, I think that was Dr. Sharma's sort of low threshold.
And now look at this E1. After that, this is a 3O. The mid portion has still not dilated. Do you have a winging of the stent at the corners? Now we are going to take the wire out of the diagonal, rewire it. Pull back more. Yeah.
I think one thing you can say is that the disease burden is heavy and it is diabetes. And one of the other discussion points you can have is you do part of this, but does a hybrid come in? Can you put a Lima to the LAD and walk away with,
We can leave it
probably the benefit that diabetics get in a 62-year-old?
So it's a really, really good question. Dr. Patel? Oh, sorry. Dr. Botello, what do you think about that idea of a hybrid?
That's a good idea, but I would invoke the functional syntax also to make decisions in such a complex case. That's a good idea. And I'd like to say that before the case, I would do completely different. I would not use rotablator, and I was concerned about the diagonal osteon. And Dr. Sharma told us did completely different from what I would do. That's amazing about the live case.
Yeah, right. And we want to see some radial. We keep seeing femoral cases, Dr. Sharma. What's happening over there?
The radials are coming. They're coming also. Yeah.
Dr. DiMarcina.
Yeah, the other thing is that, the branch isn't huge, the diagonal isn't huge, but it does have a beautiful angle for the Triton stent. Yeah. So this is actually also an attractive. Normally, I would be going exactly like Dr. Sharma's doing, except the rotablator plus minus, but But now with the Triton stent, with this type of angle, I'm more
How's that better than balloon? How's that better than ballooning in a small vessel when putting in a bare, because it's a bare stent, if, the current generation of the Triton? How is that?
Well, first of all, you get beautiful expansion at the actual ostium, and then if restenosis becomes a problem, you can always. It's much easier to treat stent restenosis than a jailed side branch with conventional method.
So it's like a culotte, right? I think it's important. We'll talk about that a little bit later. Any other comments?
Yeah, the other technique, I don't rotablate. I would not rotablate this, but what I tend to do is pre-dilate and try to get a sense of what the osteum's going to do before I go in and intervene. And sometimes I just try to get away with putting in the stent.
And as you see that the ostial diagonal has been reasonable, so what I'll do is, for the sake of time, this probably will qualify one of our less complex case. So we are ready. Anu is ready in other room. But this is a simple, straightforward, because what I wanted to emphasize only one point, and we don't have the data to support clearly, that the side branch using the flextome or angiosculpt means atherotomy to avoid that recoil which is seen many times when you put a stent across is a trouble, and therefore I preferably use the tight lesion of the side branch. Then use the usually it's the flextome, and if not disease, I just leave the wire. So with that note, I think it's a reasonable case. We are quickly done with this, and
we go to case 6, yeah?
Yep, and they are ready for case number 6.
All right, thank you so much. Excellent.